Hello, everyone. Hello, everyone. I can see we have already 60 attendees, so welcome to our session and European Public Health Week, which is focusing on leaving no one behind, and we are going to focus particularly on work we have done in Wales in relation to COVID and inequalities. Can I have the first slide, please? Sorry. So thank you very much for attending. Just to say, this work has been done by the WHO Collaborating Centre on Investment for Health and Wellbeing, and the seminar is organised together in collaboration with the Public Health Network Cymru, both at Public Health Wales. So we're a small team who has been involved into the direct response to COVID, but also looking into the wider impacts and trying to be more proactive into how we can potentially see the potential harms and mitigate and inform policies and response in Wales around mitigating harms from COVID, not only direct but also indirect. So we will follow through the slides with the team. And we'll take you through the different elements of our work. Next slide. As I mentioned, this is part of the European Public Health Week, so hopefully we'll have colleagues across all over Europe as well as Wales. And one of the topics today is leaving no one behind, and we're linked with the other webinars during the day. Next slide. For those of you who are unfamiliar with Wales, hopefully all of you everybody across Europe has heard, but maybe not don't realise that Wales is one of the 4 nations in the United Kingdom. We're quite a small but forward and outward looking country with a population of around 3 million, and of course we are bilingual, and that's why some of the first slides you've seen have been both in Welsh and English. Next slide. A quick run through the COVID pandemic and crisis we've been exposed to as the whole world. You can see here Wales, as the UK, has gone through 2, we can say 3, but largely 2 major waves. One at the beginning of last year, around March, April last year, and one sort of like a camelback more at the end of last year, beginning of this one. And then fortunately, we're doing quite well currently, but unfortunately, compared to global, and of course, there is a global and a third wave globally coming up. There's some numbers as well you can see in terms of cases and deaths and vaccination going forward. UK has had a particularly successful vaccination program, and more than 2 million people in Wales from 3 million have got already their first dose, and nearly 1 million have received a second dose as well. It's a different question, of course, around the equality of access and distribution and uptake of these vaccines, which is one of the equity issues we are currently identifying. Next slide. As a brief overview before we focus on the report itself, Wales, of course, hasn't been alone into experiencing the impact of the pandemic and responding to it. So we've been working in close collaboration with the World Health Organization, with the YAMFI, with EuroHealthNet, with other partners and networks across the UK, of course, 4 of the 5 nations, including Ireland, and also across Europe, to share experience, learning, but also to accelerate progress, progress in important areas related to addressing health inequity and making the case for sustainable investment in health and well-being, creating or making the case again for economy of well-being. There are numerous projects and programs across Public Health Wales. Some of these have been related to the direct response. The ones I've highlighted are more related to the wider impacts, and and they're also linked, and we've gathered data and evidence through these to feed into our work around inequalities. Next one. The work which is the focus of this webinar, it's part of a wider initiative. It's called the Health Equity Status Report Initiative. It's a European Health Equity Status Report Initiative. It's a European initiative supporting the and implementing, if you want, or applying in practice the principles and the agenda of the United Nations 2030 Agenda for Sustainable Development, as well as the European Programme of Work. Welsh Government signed a memorandum of understanding with the WHO Regional Office for Europe last year, 2020, in the area of health equity and enabling and supporting healthy, prosperous lives for all, while leaving no one behind. So this work is part of this broader collaborative agreement and work which started before COVID, and we are continuing after COVID, obviously looking into a sustainable and equitable recovery and building a solutions platform, health equity solutions platform in Wales, and establishing for the first time, Wales is one of the 3 countries in Europe which has established its own Welsh Health Equity Solutions platform, together with Italy and Slovenia. Next slide. We are using, for this report and as part of this initiative, we are using a new WHO framework, which provides a different and sort of an innovative packaging, if you want, or classification of the wider or the social determinants of health into 5 essential conditions. And they're very much around both the evidence, but also the policy response and the action. So largely moving from just gathering and showing the evidence into translation, and how do we translate these into effective policies and practices. So these 5 essential conditions are health and health services, health and income security and social protection, health and living conditions, health and social and human capital, and health and employment and working conditions. And we have linked them and used them as a framework to frame the wider impacts of COVID, direct and indirect impacts, which are related to increasing health inequities or highlighting existing inequities, and different pathways related to vulnerability, susceptibility, exposure and transmission of COVID. And as I mentioned more recently, also vaccine uptake. Next one. As a start of our expose and the colleagues who will focus on the different elements of the report. So this is the first report of the WHESRi initiative, and its unique characteristic or perspective is that it uses and pulls together different types of evidence and data. So we have on one side evidence from research and international sources and national and UK sources, but also we have public perceptions. So we have looked into how people are experiencing the pandemic, and we continue to look into this, and also the measures to contain the virus. We have data from statistical data and administrative sources. We also have an economic modelling. We've just recently established an economic health economics and modelling unit, and And also we have included the policy responses, and there's of course, as you know, and a lot of other countries, there have been major governmental responses and measures taken in the context of COVID. So pulling all of these elements of data evidence from health impact assessments in Wales as well, international, national evidence, modelling, public perceptions, and we've framed this into the 5 essential conditions. Next one. So I'll hand over to my colleague Anna, who will take you through the element of the international and national evidence. Thank you very much.
Thank you, Mariana. Yeah, my name is Anna Stielke, and I'm International Evidence Development Officer for the WHOCC at Public Health Wales. I would like to give you an overview of the national and international evidence, but primarily international evidence we have gathered, synthesized and incorporated into the WHESRi report, where the evidence came from and the processes we went through. Next slide, please. Part of the WHESRi report was it to provide a more global context and international evidence examples of the situation, and also provide health equity examples from before and during the COVID-19 pandemic. This not just helped to provide contextual information for the report, but also we aligned the evidence to the 5 essential WHESRi conditions. The evidence gave us a better understanding of the social, economic and well-being impacts on communities nationally and internationally. We were able to show examples of direct and indirect harms of the pandemic and which population groups have been disproportionately affected. We could see that the pandemic has affected communities around the world, directly and indirectly, and we have used the Welsh Government for Harms approach to demonstrate that. We could see direct harms from the infection and complications associated with. So, for example, COVID hospitalization admissions in the most deprived population groups were higher than in the least deprived groups. Then indirect harms due to the overwhelmed services, indirect harms from non-COVID-19 illnesses due to, for example, limited seeking and or availability of non-essential health services. And lastly, indirect socio-economic and other societal harms associated with the pandemic. So, for example, certain population groups were at greater risk of exposure to COVID-19, such as asylum seekers and refugees, due to overcrowding of housing arrangement. But before I go into more detail to show what we have found in the international evidence aligned with the 5 essential conditions, I would like to talk a little bit about how we collated the evidence. Next slide, please. We primarily used evidence and data from the COVID-19 International Horizon Scanning and Learning reports to gain an understanding of the current available national and international evidence in relation to COVID-19 and inequities. The Horizon Scanning workstream was initiated by Public Health Wales over a year ago, at the very start of the pandemic, to inform the evolving COVID-19 public health response and recovery plans in Wales. It mainly focuses on international evidence, experience, measures, as well as transition and recovery approaches in order to understand and explore solutions for addressing the ongoing emerging health, well-being, social and economic impacts in Wales. This work is aligned with and feeds into the Welsh Government Office for Science and into Public Health Wales Command Group. It has been part of a wider Public Health Wales systematic approach to intelligence gathering to inform comprehensive, coherent, inclusive and evidence-informed policies in Wales. For over a year now, we have published regular reports, almost 30 so far. The Horizon Scanning workstream includes a variety of data sources depending on the topic, including scientific literature, government and non-governmental organizations, communications, and analysis deriving from organizations such as WHO and ECDC, along with more robust clinical and academic peer-reviewed journal articles. Next slide, please. So what has the evidence shown us? Prior to the COVID-19 pandemic, we have already seen dramatic differences in health linked to socio-economic inequities between and within countries. Prior to the pandemic, health systems have already been really pressured by, for example, a growing demand capacity mismatch, focus on reactive care rather than prevention, inadequate infrastructure, acute health workforce deficiency. Longevity, lifestyle, urbanization and climate change, all of these have transformed disease burden, with NCDs becoming a global epidemic. Fundamental weaknesses in health security around the world have become apparent, showing that no country has been fully prepared to handle an epidemic or pandemic such as COVID-19. The vulnerability to the societal and economic impacts of infectious disease crisis has been increasing. Next slide, please. The disease burden has shifted from communicable to non-communicable diseases, with an estimated 41 million deaths from chronic and degenerative conditions globally every year. An estimated 700 million people have been diagnosed with a mental health disorder worldwide, and a further 10 million more cases of dementia are diagnosed every single year. Looking into national data from Wales, we can see that despite the commitment and investment towards building a healthier and more equal Wales, health inequities have persisted, demonstrating a strong relationship with the wider determinants of health. I would like to draw your attention to the figure at the bottom left-hand corner, derived from the Public Health Wales Public Health Outcomes Framework. And it's showing that 83% of those living in the least deprived areas of Wales have reported living in good health, compared to only 67% of those living in the most deprived areas of Wales over the years 2017-18 to 2018-19. Next slide, please. Communities have been impacted by sudden disruptions, as we already mentioned, in many aspects of life, and the effects of COVID, along with the related containment measures, such as, for example, lockdowns, are damaging, obviously, societies and economies, widening existing disparities, disproportionately harming certain sectors and also societal groups. This threatens to scale back, unfortunately, years of progress on reducing global poverty and inequality, and further damage social cohesion and global cooperation, already weakening before the virus struck. Wider impacts of the pandemic have been noticed related to health inequity across the 5 essential conditions, and I'm going to give you a couple of examples now. So, for example, health and health services. We've seen that COVID-19 has disrupted heavily essential services delivery for NCDs, for example, such as cancer screening and treatment, and especially mental health services, with an estimated 93% of critical mental health services disrupted worldwide. Looking at social and human capital, for example, children from deprived backgrounds have been hit harder by the pandemic due to often lack of necessary resources to support their learning progress. Next slide, please. For income security and social protection, we have seen that individuals from low-income backgrounds are disproportionately affected by a double health and financial burden. Financial insecurity can lead, for example, to food insecurity, having a detrimental impact on children's development and well-being. Looking at health and living conditions, COVID-19 lockdowns have resulted in overcrowding, an increase in violence in the home, especially intimate partner violence, and child maltreatment and neglect. Looking at the last of the 5 essential conditions, employment and working conditions, COVID-19 has hit the most vulnerable the hardest, such as those in or close to poverty, those in informal work, single mothers, essential workers. Women and young people face disproportionate risks in the job sector. To conclude, international evidence has shown that all of the 5 essential conditions for a healthy life have been impacted by the pandemic, and that the human and societal and economic costs are high and disproportionately affecting the most vulnerable in society. Thank you very much for listening. I would now like to hand over to Liz Green, consultant in public health, who will be speaking about the results from the health impact assessments.
Thank you very much, Anna. So as part of my role, I am also Programme Director for the Wales Health Impact Assessment Support Unit. And as part of the response of Public Health Wales, we carried out a series of COVID-19 related health impact assessments. And I'm just going to tell you some of the details about it, what we did, the evidence we used, and some of the findings. So next slide, please. So why did we carry out a series of COVID-19 health impact assessments in Wales? And it was to better understand the wider impacts that not just the transmission of the disease itself was having, but actually some of the policy responses and the mitigating actions that were implemented to try and reduce the transmission and maintain health and well-being. So three that we really looked at were the staying at home and social distancing policy, which is commonly referred to as lockdown, home and agile working, because many of the requirements for trying to contain the transmission was that people should work from home where they can. And also we looked at housing and housing security and insecurity mainly, and housing precariousness and homelessness. And the home and agile working HIA and the housing and housing security HIAs originated out of the staying at home social distancing policy HIA, which was much more of a comprehensive and wide-ranging assessment of the impacts. So health impact assessment is a way of looking at policy, plan or a response and asking, will it affect health and well-being? If it does, who will it affect? So who in the population, and what are the inequalities and equity implications of that, and how it affects the population. So what would the impacts be? What is playing out? And we use the lens of the social determinants of health. So health behaviours, economic impacts, environmental impacts, access to services, for example. And the series of HIAs were carried out from April 2020 onwards, and the housing and housing security HIA is just coming to an end now, so that's not yet published. But the staying at home and social distancing policy and the home and agile working HIAs are available online for people to access and have a look at, and I'll put the link in the chat once I've finished. So the scope of the health impact assessments was Wales only. They were comprehensive health impact assessments, so a wide range of evidence, including some of that which Mariana and Anna have spoken about, and which some of our colleagues, Andy is going to talk about, the Public Health Wales engagement survey, for example. And we took a wide range of evidence, so literature reviews, looked at robust papers, statistical data. We carried out stakeholder interviews with key stakeholders, including, for example, Welsh Government, the third sector, and those who represent the groups that may well be affected. We constructed a population health profile, so again some of those statistics that have been presented, and we used them alongside the findings from the public health, the public engagement survey, so what the public are actually telling us in Wales. And we carried out some virtual workshops as well, and we triangulated and synthesised all that evidence to form a coherent picture and to come up with an understanding of who was being affected and how they've been affected by these policies. So I'm just going to talk about the major impacts in the next couple of slides. So next slide, please. So I can't report about the housing and housing insecurity HIA yet because it's not yet published, but I can tell you about the findings from the staying at home HIA and the home and agile working HIA. So the staying at home HIA had a positive impact, so in many ways. So HIA looks through the lens of positive impacts, negative impacts, and unintended negative impacts, because when policies are implemented, particularly when they're formed at speed, nobody intends them to have a negative impact. And so many of these negatives are unintended, they're unintentional. But also the HIA process flags up positives, which can be maximised in the future, but also any opportunities. And the staying at home HIA identified that actually it had been a positive measure. The lockdown was a protective measure for everybody in the population, but it did flag up some major negative impacts for many people. And that included older people, children and young people whose education had been disrupted, young adults. Many young adults in Wales working the sectors that were closed down. So, for example, hospitality, leisure, non-essential retail, and that had a direct and indirect impact on them in terms of their ability to generate income, their mental well-being, and also isolation. Critical key workers, so not just health and social care workforces who were really extremely impacted by COVID-19, but also other key workers, people that you may not readily think of, but supermarket workers, to make sure that everybody had essential food, supplies, but also van drivers who were delivering those supplies. And also we flagged up those on low incomes, because furlough schemes were a protective measure, or were income protection schemes for those who worked in the sectors that were shut down. But this could also tip people who were in low incomes into financial distress and income insecurity and precariousness. When you look at those groups, you will find that actually many of them are those who weren't directly affected by the morbidity and the mortality created by the pandemic. So there are some very different impacts felt across the population in respect to the responses compared to the actual disease itself. And one of the findings of the Staying at Home HIA was home and agile working was a major positive or negative impact. And so we looked then at some of those groups who've been affected by that. And again, you can see in the list, and some of those have both been positively and negatively affected. So, for example, women have a lot of caring responsibilities, but also you could stay at home and work if possible for you. So it might make those caring responsibilities easier. So it very much dependent on the context. Again, lone parents who had to work from home and have caring responsibilities, they may be furloughed, have stresses around income and housing. So, it played out in a variety of ways across different populations. Next slide, please. And so when we looked at the determinants of health and the actual how people were affected and the ways in which they were, I apologise for all the colour coding, but the greens offer the opportunities that were identified, or the positive impacts, and the red was the negative impacts, and then the other colour is for those that could be positive or negative depending on your context and your situation. Mental well-being was identified as a significant negative impact for the staying at home policy, and likewise it could also be a positive or negative impact in terms of home and agile working. So, you've got stress, anxiety, burnout, of maybe working from home and having other responsibilities and not being able to switch off. Social isolation, if you're a lone parent or you are a lone worker, and the economic activity aspects as well are hugely important, both for the staying at home HIA, but also in terms of home and agile working. So for economic inactivity, that's the sectors that were closed down and the workers and the workforce within that. But around home and agile working, there could be opportunities created in terms of local foundational economies. So you can certainly see how it's playing out across different policies. Digital exclusion was a massive impact identified in both of these HIAs. For example, there are a number of population groups identified under the lockdown HIA who definitely did not have or do not have access to social media, to materials and smartphones in order to connect with others. So, for example, if you're an older person and you don't have a smartphone, you can't access services, it makes it difficult for you to contact people. But also many young people who live in houses and low income do not have access to laptops or notebooks that they can access their education through. So I'll put the links in the chat and then you can access it themselves. But that's just a very quick snapshot, and I'm happy to answer any questions in the chat as well. So I'm now going to hand over to my colleague Andy, and he can talk about the public perception survey.
So thank you, Liz. So could we have the first slide, please? So my name is Andy Cotter-Roberts, and I'm one of the Evidence Development Officers here at the Collaborating Centre in Public Health Wales. This next section I'm going to present to you comes from the element of our work surrounding public perceptions during the COVID-19 pandemic. As part of Public Health Wales's response to the pandemic, and particularly the anticipated toll on health and well-being as a result of the lockdown measures, a national telephone survey was implemented to help guide Welsh Government. Considering the fluid nature of the situation and a need for contemporary data, many of the questions of the survey changed during the duration of the data collection. So when interpreting these results, please be mindful of the data collection periods, which are highlighted in each of the figures. So I'm going to share with you some of our findings, organised by each essential condition. So if we could have the next slide, please. The first essential condition is health services. Our key findings here were that there were fairly overwhelming faith within the NHS within Wales, with 90% of respondents reporting that they felt the NHS was responding well to the pandemic, and that people generally felt quite safe to attend routine medical appointments. There were no statistically significant differences between different demographics, indicating that this sense of safety was something shared across Welsh society, although it's worth noting a slight negative trend between deprivation quintile and that sense of safety to attend an appointment. So if we could have the next slide again, please. So our second essential condition is income security. One of our key findings here was one that was probably to be expected, that 18 to 24-year-olds were significantly more likely than any other age category to report that they felt worried about either losing their job or not being able to find one, while 55 to 64-year-olds were significantly less likely to report that than any other age category of working age. In addition, we also found that a significantly higher proportion of respondents in the most deprived quintile reported being in a worse financial situation as a result of the pandemic in comparison to those from the least deprived quintile. If we can have the next slide again, please. Our third essential condition is living conditions. Here, when asking if individuals had left their home in the past 7 days, we found that a significantly lower proportion of respondents aged 55 plus reported leaving their house in comparison with those respondents aged 25 to 54. Interestingly, we also found that a significantly lower proportion of respondents in the most deprived quintile reported leaving their home in comparison to the least deprived quintile. We also found that a higher proportion of men across all ages and deprivation quintiles reported leaving their homes when compared with women. Next slide, please. Our fourth essential condition is social and human capital. This part of our analysis looked at individuals reporting using either social media or family and friends as their main source of information. The implication here being that these nodes of communication are more susceptible to inaccuracies or misinformation. We found that younger age categories, the 18 to 32 age bracket, were more likely to use either social media or family and friends as their main source of information when compared with those aged 35 plus. We also found that a greater proportion of men across all ages and deprivation levels reported using either social media or family and friends as their main source of information. If we could have the next slide again, please. And then that brings us to our final essential condition, which is working conditions. Our key findings were that a greater but not statistically significant proportion of females reported being employed in key worker roles in comparison to males, and that there is no clear social gradient when looking at the proportion of respondents being in a key worker role across different levels of deprivation. I'm now going to pass over to James, who's going to talk about the administrative data that we have analysed. Thank you.
Thanks, Andrew. Hi, everybody. My name is James Allen. I'm a public health scientist working in the WHO Collaborating Centre. As Andrew said, I'll be talking you through some of the statistics and administrative data that we've used to construct the Health Equity Status Report. I should firstly start off by explaining what we mean by administrative data. So basically we mean data collected by government departments, agencies during their day-to-day activities. So this could be information routinely gathered on educational records, health records, tax records, etc. So our approach for the report, we explored data published between February and December 2020, data collected and produced by public bodies, and data that aligned very closely with the 5 essential conditions needed to live a healthy life, as outlined by Mariana at the start. One thing that we do need to recognise is that at the time of the report, and now even, we're still learning and trying to understand the effects, the differences in wider determinants of health have in a COVID world. So these are a few examples that we thought we'd show. So firstly, moving on to health and health services. This is, I guess, quite a complex chart. So I'll try and describe what we're seeing to help understanding. This shows elective and emergency admissions in Wales from a period of January to August for both 2020 and 2019. We can see we've got elective admissions on the left, emergency on the right. We also see that we've got the 2019 trend in a dashed line and the 2020 trend in a constant line. The dark red shows admissions from the most deprived parts of Wales. The light red shows admissions from the least deprived parts of Wales. So what do we see? Well, certainly a notable decline in both elective and emergency admissions in 2020, significantly lower in 2019. This is particularly aligned in elective with the suspension of routine procedures at an early point in the pandemic. We can also see that admissions across the board are consistently higher in the most deprived parts of Wales. Although not explicitly stated here, but in the absence of any other metric other than waiting list size, of course, the output could be used as a proxy measure for unmet need in the population. So moving on to another example, which falls under the health, income security and social protection. We thought we'd look into the coronavirus job retention scheme and the emerging data that was being released there. For international colleagues, the coronavirus job retention scheme, it's a government wage support measure essentially designed to protect jobs in the wake of the economic impacts of COVID. So on the screen, we have experimental data looking at claims received up until the 31st of July 2020. Main message, I guess, here in Wales is that the largest sectors that furloughed staff were wholesale and retail, motor vehicle repair, accommodation, food services, and also the manufacturing industry. Whilst we were constructing the report, there was actually quite limited data on living conditions and how that has changed throughout COVID. But I thought this was quite an interesting statistic. Nearly 20%, so 1 in 5 of all households in Wales had access to, did not have access, to private outdoor space. And this was 15% in households with a shielding vulnerable person. So obviously this would limit opportunities for social interactions during the pandemic. So moving on to social and human capital and examples here, I think we're all, the link between education, level of education, and level of self-reported health, mortality, morbidity is quite well established and understood. We looked into educational attainment gaps present between children aged 16 in Wales. So on the output, it's labelled as General Certificate of Secondary Education. For European colleagues, that's the standard sort of qualification at age 16. We looked at the differences here between children who were eligible for free school meals and children who weren't eligible for free school meals. So what are we seeing? Grade A, so that's a very good grade. The attainment gap has increased in 2020 compared to previous years. Grade C and above, so grade C, more mid-level grade, the attainment gap there is actually decreased. So although we are yet to quantify the effect, and I guess this will only become tangible in years to come, the increase in gap at grade A is concerning for inequitable outcomes in the future. So last condition, the employment and working conditions. I'm sure we're all very well aware of the environment in which our key workers have had to and continue to work actually in a COVID-19 world. The output on screen is showing deaths involving COVID-19 among health and social care workers and comparing this to people in the population. And I should mention it focuses on the age group 20 to 64. And is based on the period 9th of March to 28th of December 2020. Quite a stark message, actually. So the rate of death involving COVID-19 in social care workers significantly higher than healthcare workers, and also significantly higher than people in the population, more so in males. Also, healthcare workers in males significantly higher than the general population. Actually not the case in females though. So yeah, I guess this outputs a stark example of the disproportionate impact your employment and working conditions can have on health, morbidity and mortality. As I said, these are just a few examples. There's a lot more information in the report. I'll now pass you on to my colleague Raj, who will be talking through some of the economic modelling that was conducted for the WHESRi report. Thanks.
Thanks, Jim. Good afternoon. I'm Rajendra Kandil. I'm the health economist at WHESRi. I'm leading the economic application of public health programs. Next slide, please. Within the next 5 minutes, I'm going to be talking about the economic consequences of COVID-19 on the long-standing illnesses, including chronic health conditions, with a focus on the health consequences of unemployment. For this study, historical data were retrieved from the Office for National Statistics and the National Survey for Wales and used the time series models to forecast unemployment rates and long-standing illnesses. We consider unemployment as the economic proxy to forecast the percentage of adults with long-standing illnesses and the chronic health conditions. The forecast was done for 3 financial years starting from year 2020. The forecast has been performed for 3 different indicators types: unemployment, long-standing illnesses, and chronic health conditions, and the results are presented in the following slides. Next slide, please. First, I will discuss about the unemployment forecast. Without reparative interventions, unemployment rate was expected to increase sharply from 3.8 in 2019 to about 7% in 2020, following COVID-19 pandemic, and this would have been gradually increased over the projection periods. However, due to the introduction of government economic measures such as furlough scheme, the unemployment rates remained steady for 2020. From the historical trends, we could see sharp rise in unemployment following pandemic or in case of economic recession, which we can see in the chart following economic recession in 2008. Next slide, please. This chart is related to the forecast for long-standing illnesses. With increased unemployment rates, long-standing illnesses is expected to increase about 4% over 3 years following the pandemic. The trend were either stationary or increased slightly before the pandemic. The higher increment is expected for limiting long-standing illnesses, but the figure for this has not been presented here. You can see details in the full reports. Next slide, please. This slide is related to the forecast for chronic health conditions. With current unemployment forecast, the percentage of adults with chronic health conditions is projected to increase substantially following the pandemic, with higher increment observed for mental health problems and metabolic conditions. These health conditions trend were also either stationary or increased slightly before the pandemic. Next slide, please. In brief, the long-standing illnesses and chronic health conditions are expected to increase in the coming years following the COVID-19 pandemic and associated increased unemployment status. There are several factors which influence the increase in those health problems, such as aging population, the COVID-19 associated restriction measure, and the suspension of non-urgent outpatient visits and elective admissions could further complicate the situation of long-standing illnesses and chronic health conditions. Therefore, these health problems should be considered as part of the COVID-19 recovery measures. Thank you for listening. Now I'm going to hand over this platform to Ms. Shah, who will be talking about the policy aspects around the COVID-19 measures. Thank you.
Thank you, Raj. And hello, everybody. My name is Mich van Eimeren. I work as a Senior Policy and International Evidence Development Officer at WHOCC in Public Health Wales. My work mostly focuses around equity, COVID-19, and the public health implications of Brexit. I will use my 5 minutes today to briefly discuss the Welsh and UK government policy response and the methodology we used for our analysis. Next slide, please. Following the COVID-19 outbreak in Wales, the Welsh and the UK government have adopted a broad variety of guidance and policies as part of the COVID-19 response. These policies and guidance documents have been updated continuously throughout the pandemic, depending on the situation on the ground. Many of these guidance documents or policies contained elements of addressing equity or inequities in Wales. I'm, for example, thinking about the additional 1.5 million to services for violence against women, domestic abuse and sexual violence, or the suspension of housing evictions. Wales is a very outward-looking nation, and some of its policies have been inspired by international guidance or recommendations from institutions like the WHO, the UN, and other nations. As Anna already mentioned, Public Health Wales has helped Welsh Government in monitoring and collating international evidence and published the content in publicly available reports. Next slide, please. So here we are seeing the methodology behind the policy analysis for the report. As you can see under point 1, we assessed more than 2,000 documents to really understand the main issues in society and the mitigation measures the Welsh and the UK government have taken in Wales. For this exercise, we closely worked together with our colleagues from Welsh Government to ensure we did not miss any key policies or guidance documents. This exercise led to the inclusion and sometimes more detailed description of over 70 policies in our report. In terms of limitations, I think it is important to mention that while the process has been thorough, we cannot guarantee that we have been complete, and it is certainly possible that some policy or guidance documents have been omitted. Secondly, we focused on policies, guidance documents, and sometimes also reports adopted during the COVID-19 pandemic. And with the exception of some pre-COVID-19 key overarching policies and legislation, such as the Wellbeing of Future Generations Act, we have not always taken into account other non-COVID specific policies that were in place before the pandemic started. Moreover, the COVID-19 situation is extremely fluid, and many of the policies in the report may have lost their relevance by now. Finally, many new policies are continuously being adopted, at the moment mainly in relation to the ongoing vaccination efforts and the relaxations of some of the restrictions. Next slide, please. So yes, as already mentioned, we have observed a vast amount of policies and guidance documents that have been adopted by the Welsh and UK government, addressing almost all aspects of our lives and with the purpose to mitigate the many harms resulting from the COVID-19 pandemic. However, as my colleagues presenting the data have shown already, despite all these efforts, inequity have persisted and unfortunately further exacerbated in Wales. The groups that have been disproportionately affected, but there are many more, include BEMA, communities, young people, women, children, prisoners, and elderly people. On the next slide, I will describe some of these impacts in more detail. Next slide, please. So here you can see an overview of one of the 5 case studies we have used in the report to describe certain harms resulting from the pandemic and the concrete mitigation measures that have been implemented by the Welsh and/or the UK government. Especially in the beginning of the pandemic, there have been issues for adults and children to access food for different reasons, including due to self-isolation of elderly vulnerable individuals, or as an immediate effect of the closing of the schools, which automatically put the daily school meals on hold. Another reason was reduced income, as many people lost their jobs or have been furloughed, which led to more people seeking assistance from food banks. A broad variety of measures have been implemented by the Welsh Government to address these issues, including a national food parcel delivery scheme, school meal provisions, including during the holidays, and the Discretionary Assistance Fund, which provides grants to pay for essentials, including food and utility bills, and which does not need to be paid back. So thank you for your attention. I'm now handing over to Mariana, who will discuss the way forward, including the opportunities that have arisen from the pandemic.
Thank you very much, Misha. And I can see we are also advancing in time. So I know my colleagues from the network have invited you, and please do post your questions in the Q&A. If we don't have time at the end, we will address them afterwards and email to you. So please welcome to ask any questions. I'll wrap it up quite quickly, so we might have 5 minutes at the end. Next slide, please. A few key messages. We have identified key messages under each of the 5 essential conditions areas, but the main things I will highlight for the whole, which comes through all of the evidence and through the whole report, is COVID-19 obviously has exacerbated existing health inequities. It has also exposed new vulnerabilities. It has also exposed the fragility of health systems and capacities, which Anna has nicely explained at the beginning, and some groups have been particularly and disproportionately affected. So, for example, children and young people, largely due to indirect impacts, minority ethnic groups, especially Black and Asian, which is true for the whole of the UK, people living in or at risk of poverty and deprivation, people not only unemployed, but people in low income or insecure or informal employment, especially women, and then particularly marginalized and socially excluded, such as homeless and refugees and asylum seekers. However, as every crisis, in an unfortunate way, COVID has provided opportunities as well. And there is an opportunity to, as WHO says, build better or have a recovery which is both sustainable and more equitable as the status quo before the pandemic. So ideally, we don't want to return to the status quo before the pandemic, and we do have an opportunity working with partners across sectors to prevent actually a crisis like this next time. It can be an infectious disease or an environmental crisis or a financial crisis or economic crisis, which we had 2008. So ideally, we would like to prevent it rather than only prepare better for it. Next slide. I'm not going to go through all of these. We have identified some levers and enablers which can help such sustainable recovery. And some of these are related to digital technology, using digital technology, adopting a circular economy, adopting new holistic socio-ecologic indicators, and also having an intergenerational lens to response and recovery policies. There have been some positive impacts of the COVID pandemic, which we have identified in relation to active travel, community assets, and also supporting the local economy. Wales has been quite prominent actually in this area, as I mentioned, with the MOU and the work around WHESRi, and more recently with the socio-economic duty, which has come into force in March 2021. So in a way, Wales is leading the way in Europe, at least, if not globally, towards a more sustainable, of course, based on the Future Generations Act as well as a sustainable development legislation. So towards a more sustainable investment into health and well-being. And we have really now, COVID has highlighted the importance of public health, the importance of prevention and early intervention, and that it is an investment rather than a spending into these elements of the health service, which are important to prevent future crises and pandemics like this. So I'll wrap it up here. I think we have another slide around twittering, so feel free to Twitter. And I didn't present myself at the beginning, but I have the pleasure to lead the international health team, and as a deputy director of the collaborating center, I'm a consultant in public health as well. But feel free to ask also any questions. I can see we have just a few minutes for a couple of questions potentially, and if we don't have enough time, we'll answer them afterwards. So I have one question from Learning Disability Wales, mentioning why do we not have disabled people mentioned in the HAA's list? This is particularly for you. Just to mention beforehand again, and Misha mentioned this is not an exhaustive report. In any case, again, we have tried to pull together, it's more of a wide breadth, having a wide breadth, showing the different elements which are important, the public, the data, the evidence, the economics, but it's no way exhaustive. So and we couldn't, of course, present everything which is in the report in the different sources of information and data anyway. But Liz, maybe you would like to mention something around the impact on the disabled people.
Thanks, Mariana. Yes, I've just answered it actually in the chat because I didn't know if we were going to have any time or not. But in terms of the home and agile working health impact assessment, we found that actually there could be opportunities for those with disabilities because you know, it will enable a diversity within the workforce and a diverse range of people who may currently find it very challenging to actually access economic opportunities and working opportunities, because you will be able to remain at home and actually have your fully adapted situation. So actually we did find that could be an opportunity and a positive impact going forward.
Thank you. Thank you very much, Liz. For this, we're approaching the end. I can see a couple of more questions which we will be able, one is related to the case study, which hopefully we'll be able to answer afterwards. And comparing Wales. So in terms of, I can see a question around carers and their opportunities. We did have, again, we looked into social health and social care, and in particular there was obviously a mention around the high risk of exposure and the impact, in particularly mental well-being and lost quality adjusted life years. We have data around particularly social health and social care workers. So it's definitely there is definitely information. We have highlighted this. In terms of comparison, we have been looking, we have done, as part of the International Horizon scanning, we have been doing also insights into specific countries like Iceland and Israel. I can see comparable size nations. So, of course, the pandemic has been moving in a different pace during the world and in the UK and Wales. So, in some ways, at the beginning, we have been learning from other countries and their measures, while later on we have been also already providing our own experience and practice to other countries. So thank you very much for attending. The more specific answers to your questions we can post afterwards. It was hopefully this was useful, and if you have any further questions, or if you would like to continue discussion and or maybe to explore synergies and collaboration, please do contact us, and feel free to contact us, and we can follow on after this webinar. Thank you very much for the team and for the huge effort they've put into producing this work over the last 6 months in parallel with health protection, direct health protection responsibilities we have been doing dynamically. Thank you very much to the network of helping organize this webinar, and of course to colleagues in UFA and organizers of the European Public Health Week. We very much hope this has been useful and part of the general conversation around the health equity agenda and addressing inequalities and impacts of COVID going forward. Thank you very much.